My research through the Center for Biostatistics and Epidemiology began a little over a decade ago. At the time, there was a lot of interest in hospital readmissions, but there was not a lot of attention being paid to people with diabetes. So we set out to better understand why people come back to the hospital when they have diabetes, and we did a number of studies in both qualitative and quantitative work. Then we turned it into the Diabetes Early Readmission Risk Indicator, or DERI for short. This is a predictive model that, with 10 simple items, can generate readmission risk predictions for individual patients.
If a patient after discharge from the hospital, and then based on their profiles, we can calculate how likely they'll be come back to the hospital again within the next 13 days. It's pretty accurate. And actually, we developed a tool called Diabetes Early Readmission Risk Indicators, which is a tool can identify who are more likely to be readmitted.
So the next project was to develop a model that could be integrated into an electronic health record system and automatically generate risk predictions without regard to how many variables you had or calculations or human labor to enter the information. So this we call the eDERI for electronic, and this is the project we're engaged in now, trying to upgrade the DERI models and develop them into an EHR-based application. And the center is supporting this work in that we're using the PATH Clinical Data Research Network, and we are leveraging artificial intelligence machine learning to develop those models.
So we have seen in other fields benefits of personalized recommendations. Yeah. Netflix does that, yeah. Spotify does that. Yeah. In healthcare, we want to actually go very similar approach, use machine learning, yeah, to improve quality of service, to go predictive. So in order to see, given that this patient has some diseases, yeah, there's a risk for complications. There's a risk for patients getting other diseases here. So we want to learn not just from one person, but from the whole number of people. And joint learning, that's what machine learning actually has potential, could possibly actually go beyond what any human can do on their own.
My interest in artificial intelligence machine learning in the past few years happened to dovetail with a large NIH-funded program called AIM Ahead, which is a multi-institution collaborative designed to help underrepresented minorities conduct this kind of research using artificial intelligence and machine learning, and bring those institutions into that kind of research to develop their capacity to do it. So I'm proud to be leading Temple's contribution to that in the infrastructure core.
Dr. Rubin is a fantastic example of the consummate physician scientist here at Temple. He started his career looking at the mechanisms of disease and the immune system. He then went on to investigations in therapeutics, and then started to look at population risk factors. Despite best efforts, patients may remain at very high risk for readmission to the hospital or bad outcomes from diabetes. And now his career is taking him into the world of big data, with looking at large databases and electronic health records, and looking for signals and opportunities for us to identify where we can make a clinical difference with the care of our patients.
I was here for a study for diabetes. When I came in, my diabetes was high, and that's when they kept me in the hospital, and I didn't know nothing about diabetes or nothing like that. They taught me everything about it. I feel good, like I got it under control, and now Mo was under 120, and they have me as pre-diabetes now.
This is an exciting time for research here at Temple, particularly as we look to what we call translational research. So our basic scientists in the Lewis Katz School of Medicine and Temple University, working side by side with our clinicians providing the clinical care, developing programs not just based on the mechanisms of disease or even the therapeutics, but also looking at the population and population health and seeing how our therapeutics and our basic science influences can affect the health of the population and, in the end, give us better value for our patients.
So in the next 5 years, I think we're going to continue this trend toward increased use of artificial intelligence and machine learning. There's been an explosion of this work in the past decade, and I think in the research realm, in the clinical realm, and really in the public realm, we're seeing continued growth of artificial intelligence and machine learning. So it's very exciting to be able to leverage that technology to be even advancing machine learning methods, using things like deep learning approaches to better develop predictive models to help people with diabetes.